Proximal anastomoses of venous grafts are usually done either after the cross clamp is released and all distal anastomoses are constructed, or less commonly using the single clamp technique, which involves constructing a reciprocal proximal anastomosis after a distal one. The completed anastomosis is shown here. Notice how the graft vessel is attached distally to a coronary vessel and proximally to the aorta. If this is being done as the second step, a single period of aortic occlusion and intermittent retrograde perfusion via the coronary sinuses is performed. Notice the positioning of the cranial and caudal ends of the patient, the aortic and venous cannulae, the ascending aorta, and the combined cardioplegia and root vent cannula. The command is given for cardiopulmonary bypass flow to go down. The side biting clamp is applied. The advantage here is that the myocardium can be reperfused while the proximal anastomoses are completed. We can see the ventricle starting to fibrillate. The command is then given for the flow to come back up. The combined cannula is removed with its purse string and its hole is used for proximal anastomosis. We then proceed to prepare the site. Start by dissecting off the adventitial fat overlying the aorta's anterior wall. Then after making a small incision, use a hole punch to make a small 4 to 5 mm opening in the ascending aorta. With the site prepared, we prepare the graft for parachuting. The graft vessel should be measured to length and cut back appropriately. The length of the cut should be sufficient to reach the aorta without placing stretch or tension on the conduit, but not so long as to kink and obstruct blood flow. Flatten the graft vessel with a Cooley infant vascular clamp. Expose the heel. Now that we have prepared the graft, we can begin the ligation. We will place 5 loops of 5,0-polypropylene around the heel and through the aortic wall. The stitches should include 3 to 5 mm of the aortic wall to ensure adequate strength of the anastomosis. Make sure to maintain traction on the suture and the vein graft to expose the edge of the aortic opening for accurate needle placement. 2 of these loops will be placed to one side of the apex of the heel, the third precisely through the apex of the heel, and 2 on the opposite side of the apex of the heel. After that, pull on the ends to approximate the graft to the aorta. The heel of the graft should face directly left for a left-sided graft and caudally for a right-sided graft. Now we complete the anastomosis. Complete by wagon wheel suturing around the aortic opening you've made. The aim of this is to spread the sutures out radially, thus evenly spreading the tension over the aorta. This can be accurately visualized by observing the edge of the graft vessel and the aortic intima by retracting the graft with forceps and slightly relaxing the suture. Along the lateral edge of the graft vessel, take wide stitches with narrow corresponding stitches on the aorta. This is to ensure the maximal length of the graft vessel is positioned laterally. The direction of the stitch for left-sided grafts is clockwise around the heel and counterclockwise around the aortic opening. For right-sided grafts, this is counterclockwise around the heel and clockwise around the aortic opening. The command is given for the flow to come down, and the side biting clamp is released, tying down as the flow is gently increased again. This allows de-airing of the graft before tying down the knot. After the knot is completed, the soft vascular clamp is removed. which allows flow to be established down the graft after the de-airing maneuver is completed. Tying down the anastomosis after removing the side-biting clamp allows the knot to be tensioned onto the pressurized aorta in a natural anatomic configuration. The end result should bulge anteriorly above the aortic wall, with a cobra head appearance. The procedure can be summarized in 3 key points. The command for flow to reduce is given before placing or removing the side-biting clamp. Just after each, the command is given for flow to increase. In preparing the graft, cut it in such a way as to ultimately keep the flow patent, without tensioning or stretching either the graft or the aorta. Suturing is first done from the inside out for parachuting and outside in for completion. It is important to distribute the radial sutures evenly along the circumference of the opposed graft and aorta in order to evenly distribute tension over the aorta.